Hello and welcome to the Novello podcast, where we talk to wonderful people, all with experience of working in or with the NHS, about the challenges of creating an NHS that's fit for generations to come, and with a particular focus on driving a sustainable workforce. Today, we've got Billy Palmer, who works for the Nuffield Trust as a senior fellow in health policy. Billy and I have met a couple of times in the past, and I've always found his insights incredible. So I'm very excited to have him on the show today. Hi, Billy. How are you?
Yeah, I'm good, thanks. Enjoying the sun.
Yes. Nice to have a little bit of sunshine for a change, isn't it? Thank you for joining us. We've lots to talk about, so I thought we would start with the long-awaited NHS long-term workforce plan. I'm aware that maybe some of our audience might not have read it cover to cover, so perhaps we could start with you just sharing what some of the highlights are from it, from your understanding.
Yeah, well, I mean, what immediately jumps out from the long-term workforce plan is the ambition in terms of the numbers are vast. So whether that's the training numbers, it's broadly looking at about two-thirds increase in clinical students. For some staff groups, it's actually doubling. So for medics, for example, it's a doubling of numbers. That's that's very significant. And it's also vast in terms of its ambition for the projected workforce numbers by the end of the sort of 15-year period that it covers, and nearly a million more NHS staff, according to their sort of central estimate.
Yeah, there's quite a lot of big numbers in there, isn't there? And do you think that it goes far enough in terms of talking around how we're going to deliver those numbers?
Wow, that's the challenge. How do you deliver them? And I guess we have to first of all recognize what was the long-term workforce plan, and in part, though it wasn't the stated ambition, this was a document to try to build consensus for a future sort of funding and shape of the NHS. And that's sort of my view in terms of why it was developed in a certain way and presented in a certain way, and that's that explains why it is very bold in terms of those overall numbers, but possibly explains also why it's a bit lighter when it comes to actually what are the mechanisms for delivering on this, because I guess that comes in the future stages. And in fairness to the the team and and government and departments working on it, they've always said that this was the first of many, and indeed, a huge amount of endeavour went into trying to create this first one. But clearly, there are gaps in terms of how do you get from the current situation to point B in 2036.
Yeah, yeah, and a lot's changed already, of course, in since it was launched. You know, we've had a change in government in that time. Do you think that will change what that workforce plan looks like?
I think potentially to a degree. I think well, most parties in some respects have sort of accepted the findings of, well, they accepted the sort of recommendations of the long-term workforce plan. It's slightly unclear what they're accepting. I suspect it means they're accepting the short-term increase in staff numbers. I'm not convinced as yet that uh, anyone's actually making a firm commitment on actually having the resources there to employ these staff at the end of it. And that is, in terms of what's missing from the plan and from the initial announcements that went into it, there was lots of talk about it being funded, but actually it was funded only in the very narrow sense. It's in the next few years, well, not even in the immediate terms, but in sort of this medium term, would they be providing some cash for additional education placements? That that doesn't help the NHS actually deliver more services. What's required there is actually to employ the staff at the end of it.
Mm.
And I guess in terms of a change of government, will they make commitments in terms of that funding available? You know, just to give a scale of this, the Institute for Fiscal Studies, did some estimates in terms of if you were to increase the staffing numbers and the sort of the associated resources that would need to go alongside that by 2036, that would be the cost of that would be equivalent to adding 7 percentage points on VAT. There's a huge financial implications. So, you know, we don't know what the government will do on that. We don't know much about what this government has planned. Its manifesto, and we commented on this at the time, was very light on actual sort of commitments and policies. That's not to say they don't have plans and they don't have ambitions around that, but we don't know quite what those are. And I mean, we've seen even in the last 48 hours some announcements and suggestions around what will happen with pay. That's clearly a key factor.
You were talking there around how, will the budget go far enough and things if you want to continue.
Yeah, and as I was mentioning, just the scale of the finances that would be needed to, and what we've seen in the last 48 hours is about this, the pay side of it, and um, yeah, in terms of creating the numbers in the workforce plan, what happened was there was a very detailed exercise looking at, well, how would patient need change? But actually, that's just one part of the equation. Actually, what defines the number of employed staff you have is, the funding available. And the funding available is not only that political decision, how much we spend on healthcare, but also how much do your staff actually cost. And
Mm.
you know, the pay settlements, or suggested pay settlements for most staff, those on the what was the old Agenda for Change contract, and even suggestions about what might be the offer for junior doctors. And that, of course, changes the dynamic in terms of the number of staff that might be afforded with the same amount of money. So, yeah, huge questions remain in terms of, you know, will the reality look anything like what's been projected in the long-term workforce plan?
Mm. There's so much to cover, isn't there? I mean, it's just such a massive challenge. It's almost where to start. And I think for me, just creating the plan was a good place to start. Even if there's bits that it doesn't cover, or there's bits that perhaps need a bit of work, and I'm sure it will evolve over time, and I hope that it does evolve over time. Um, it was a good place to start. There was no workforce plan since early 2000s, and there's lots in there, and they've split it into three great sections around the train, retain, and reform. Um, I mean, just reading it, there's a lot of statistics in there in the train area around education and training. You've done a lot of work, Billy, over the years around data analysis. Very good at the data. You'll know that data probably more so than a lot of us. Even before that long-term workforce plan came out, do the numbers stack up? Do they stack up with the data that you analyse and look at?
Yeah, well, I think when we saw the actual scale of the numbers, and I think it's worth repeating this point of it's good to have been bold. The cost of an undersupply and having too few staff being trained or being employed is worse than the cost of an oversupply.
Mm.
Um, and we might get back into the history, the terrible history of the NHS in terms of undersupplying and why that might have been. But it was good to have that ambition. In terms of did they stack up? I mean, clearly it looked. I think at best you would say challenging, and our concerns around that were, confirmed by the government spending watchdog, the National Audit Office. They looked actually at the modelling, the actual numbers, a couple of months ago, and they weren't able to replicate some of the numbers. So there's a point around accuracy there. There's also some questions over whether the assumptions were wholly realistic, and they point out some of them, particularly around productivity. There's a very large assumption there that effectively by becoming more productive, you can reduce about sort of 170,000 full-time equivalents worth of staff by somehow working more productive. I mean, that's sort of a big number. And then there's this huge number of additional uh, people being trained, and that comes at a cost because you have to provide clinical placements, you have to provide the educational capacity, and the National Audit Office, they pointed out that that was the very high end of what was plausible, um, and we're already seeing some challenges. Probably it's earlier than even I thought when I had concerns about this in terms of the difficulties in trying to deliver that sort of what even the current level of training
Mm.
in a service that's running very hot and trying to work out what is a vast backlog of care. And I think that was possibly one of the largest sort of omissions from the workforce plan. The calculation was just really taking to account and having a clear strategy and set of incentives and and funding and all the associated resources to actually deliver on that training side.
Mm. Yeah, yeah. There's a lot of numbers in there, aren't there, to kind of plough through, and there's some that were quite early targets to meet, certainly by 2025, and I think they had said that there would be an update, and they would have a look at it every 2 years and publish something around how they were getting on against those targets. So do you think we're to expect something in 2025 around how they're getting on against those first targets that they set of themselves?
Yeah, I think they definitely seem to, well, they've made a firm commitment around having these updates, and that's a good thing. Um, and if we reflect back on how a workforce plan would have looked 5 years ago, you would have instantly had to update it when the headwinds changed and COVID hit, and then there was various issues affecting even broader issues around inflation and how that affects costs and the ability to deliver services. So you're always going to have to update. And I think when it comes to a plan of this scale, it's going to be important to monitor it and check what you're doing. I think in terms of what might we see by 2025, there are some interesting but very lightly defined proposals in there. So, for example, the possible use of tie-ins for new dentists to actually work in the NHS after qualifying. There's suggestions there about paid internships for doctors in training and for sort of earlier employment of nurses. They would need to be fleshed out pretty quickly. Um, and I think the other one is on medical apprenticeships as well. I think they're already behind in terms of their timescale for that. So yeah, I think we in a position by 2025 we'll have a real idea about whether this will move beyond what was a lobbying document to Treasury to try to get some more immediate funding for training to actually being something that is a fully considered viable plan for the workforce for the NHS.
And I mean, so much of it resonates for me in running a business. In that, and I know that might sound a little bit silly because obviously this is just huge compared to running a business. It's on a scale that I can't comprehend really. But the challenges are the same in that there's so many elements to creating this sustainable NHS. It's not just about training. It's not just about hitting a target on education. It crosses through culture, and culture, I think, is the most difficult thing to achieve because it's not always something you can put your finger on and put a number next to. It's people and it's emotion and it's a feel and it's um, it's so much more than just data can provide really. But I think that is such a core element of what's needed here for the NHS. I mean, there's talk of when we spoke a couple of months ago, Billy, and one of the things that had jumped out from this workforce plan was it was the first time really that they'd recognised that temporary staffing would play a part in it. Albeit they want to reduce the reliance on it, and rightly so because of the spend that's attached to it. But a real recognition that temporary staffing plays its part. Um, and that really is linked back to culture, isn't it? There are reasons around the culture that people choose to do temporary staffing, not just pay, but how they feel when working in the NHS, and some of the issues that they have become tired of and burnt out by the pandemic and the lack of support or childcare support, or they've talked around the pension reform. But I think that culture piece is really hard, isn't it? That retain side.
Yeah, and actually the culture also plays into sort of almost that recruitment. And well, I guess there's recruitment and there's the very early careers retention, and then there's longer term retention as well. And the culture is seemingly shifting fairly quickly. I mean, if we look, for example, at the NHS staff survey, there's some reported measures which have remained fairly consistent, but we also see some differences, particularly from sort of younger generations coming through and some of their career behaviours. And there's an opportunity here because when we were involved in a survey just a few months ago, asking people who are essentially prospective university students about their sort of attitudes towards clinical careers, and a huge amount of them consider it because they want to have sort of an altruistic. They're quite motivated by some of these sort of altruistic benefits of such careers. And but yet we're not quite tapping into them. They have, a sort of perceptions of the workload, which put them off it, perceptions of pay, which are putting them off these careers, and that's very regrettable. And some of that is a communication issue, and some of that's the reality of it. I mean, there's so many people working in the sort of the wider uh, health and social work sort of sector, social care sector, that people will have a bit of an indication of of the pressures on the ground. And so there needs to, there is this element in terms of, you know one aspect of culture is, making sure you understand the motivations of your workforce. And there's a huge number of people who are fairly new to the NHS, actually a large number of people who are new to the UK as a whole. And I think the NHS in the past hasn't been that good at picking up on what really are the motivations. And if you don't do that, you end up defaulting to some sort of lazy, sort of partial understanding. And very quickly, the arguments will then become around things like pay. And it's not just about pay in
Mm.
terms of how do you recruit and retain staff, but in lieu of better evidence and a better understanding of motivations, then that just becomes the central conversation. And that's very problematic. So there clearly is a big piece to be played in culture. I mean, there are huge cultural issues at the moment. Some of the particular debates around skill mix and some of the emerging staffs has not been wholly pleasant, particularly for those involved. And we know there's issues in terms of racism, discrimination, and some of the other sort of challenges the NHS is facing. I would say on the plus side is the NHS also knows and has experience of doing this well. So just before the pandemic hit, there had been a couple of years of a nurse retention program, nationally sort of sponsored, which was interesting because we're fairly certain it worked in terms of it reduced nurse leavers, and it actually appears to have saved lives. They managed to link it
Oh, wow.
to those trusts that were doing the program, and they linked that to actually mortality rates, and they seem to have saved lives. There's quite a lot of uncertainty over the exact scale of it, but it does seem to have had that positive effect on patients. And the interesting thing about that program is you can characterize it by there were no targets. There was not a central target of how many we would say, and it wasn't cascaded down to individual trusts to say you must reduce your retention by X percent. Effectively, all it looked like was the central team said, we can provide you some support and we can provide you some frameworks to think through what your strategy should be, and then we'll allow you to go on and do it. And it turns out that's a good way of managing the NHS because that seemed to work. And what I'd like to see, and maybe what was slightly missing from the NHS workforce plan, was reflecting on what has worked well, and rather than trying to reinvent and start a new retention program, say, well, look, we know the characteristics of how to manage services well. Let's use that sort of philosophy and principles and build on it.
And because that's really interesting. I mean, I've worked with the NHS for 15 years now, and I wasn't aware of that scheme being piloted. You kind of feel like saying, let's shout about the good things that are happening, because the media so quickly jump on negative stories and negative press, and we read about that all the time, but we need to shout about some of the fabulous things that are happening. What happened to that scheme, Billy? Are they still doing that anywhere, or did that kind of go by the wayside in the pandemic and hasn't been?
Yeah, it did to a degree, and then it was sort of usurped by as a sort of new one led by the sort of people directorate within NHS
Okay.
England. So it's a slightly different shape to it, and that could well be working well. I don't know, but there's not been the same formal evaluation that I've seen, and it just felt regrettable that that hasn't. I've been trying my best to shout about these things
Maybe
working,
this
but
podcast will help. Maybe we can get.
yeah, and I think there's a human tendency. We know it's a bias about wanting to have sort of ownership
Mm,
over some of these programs, and so I think there's a risk that we always try to reinvent, and we don't need to. I
yes.
mean, the NHS has experienced most things, and there's a real risk that we always think, oh, this is the only time we face these types of challenges or issues. There will always be something that's at least adjacent to what our current experience is. Well, let's learn from what happened before. And I just don't see that
Yeah.
in some of the current thinking and strategies that come out.
And I think you know, the NHS is so big that sometimes the messages and these things maybe don't reach the people that need to hear them, and that's what this podcast was set up for, really, and trying to speak to as many wonderful people that work with and for the NHS, that have all this experience, that have all this knowledge, and getting it to reach the right people to kind of drive change in a positive way would be, would just be great to do, wouldn't it? But keeping in that culture side of things, they talked about needing to. There's obviously an awareness now of needing to allow a greater level of flexibility for staff in the NHS. That's obviously come out of staff surveys and things as to why people perhaps turn to temporary staffing and working for agencies and so forth, or perhaps even leaving the profession completely, which I've spoken to people that have done for that reason. Do you think that? I mean, I think my question is what does that look like, and will it go far enough? Because we're working in a society now, since the pandemic, things have changed. There is a, a greater need for people to have this flexible working. People have realised that they don't need to commute long distances. They can do things over Teams. They expect a greater level of flexibility and a greater understanding of that need for work-life balance that I think the
Yeah.
healthcare profession have never had. They're completely dedicated to their work in most scenarios that I know, most people that I speak to, and that's a lovely, lovely trait. But often that's at their own expense, either with their family or their well-being, and trying to kind of address that rebalance is going to be a big task in a society that is moving towards people being more self-employed, wanting more flexible working. Can the NHS reduce their reliance on temporary staffing when that's a global trend?
Yeah, I mean, if we, yeah, you raised the sort of key phenomenon here, which is that people seeking more, well, firstly, work-life balance, and then increasing challenges around uh, some of the sort of constraints of working with their outside pressures. So whether that might be parental or caring responsibilities. Um, and we've seen, for example, a very radical increase in the number of people leaving their role because of work-life balance. And we've certainly, heard about some of the pressures regarding, people trying to work with their parental and caring responsibilities. And we see that right from day one when it comes to how we educate and train people. And do we offer them the flexibility within that sort of training environment? And there's still a little bit of a sort of a hangover of, well, I didn't get those opportunities when I was training. I had to work this many hours. And well, firstly, the service has moved on. There is some more flexibility afforded to it. So let's not try to sort of arbitrarily punish people, um, in their sort of a very formative period of their careers when they're doing their training, and possibly when they're sort of most vulnerable and have particular issues when, particularly sort of financially, and how they might be able to react to some of those uh, challenges. But there have been quite a lot of sort of stated ambitions in terms of flexibility, and they have seemingly, moved some of those terms and conditions around, you know, having that ability to request flexible working from day one. I think these are all positive moves. I think it's very important to be monitoring how that plays out, and what are the models and sort of decision making around that to make sure it happens fairly. I think when we've looked at particular staff groups, it's done more so for certain professions and certain levels of seniority than others. And I think it's given, you know, the way that people communicate, and and the fact that people can see, how job roles are described on, and they certainly do comment on social media about how job roles are described, uh, uh, and then, actually what people are getting in terms of flexibility to make sure there is consistency. So, like, just taking one example, when we looked at clinical support workforce, and then compared that to consultants, you have very different levels of pay in those two professions. One of which they were typically demanding absolute flexibility from the person joining the workforce to work around shifts, and the other they were offering all degrees of flexibility for people to work. I mean, there are of course different job markets, but there is, I think, a real risk that we don't apply that flexibility in a fair way, and it's leaving quite a lot of responsibility for line managers and those sort of smaller team directors to actually manage that. And one thing the NHS doesn't have in huge quantity is that frontline organisational management capacity. And so I think there's a real shift that some of the ambitions nationally are just cascaded down, and just a hope that somehow within the system they'll pick up those challenges. So it's a great ambition, and by no means I want to sort of roll back on that at all. But I think there is some, I think some real supports needed in terms of making sure the NHS can do that, effectively and fairly, I think.
Yeah, yeah. I think, as we say, I mean, a great step to have a plan. But I think the next phase, hopefully, to evolve from this is that how piece. You know, how do we deliver it fairly, consistently, and in a way that's going to have an impact, you know, and really drive that change. And change takes time, doesn't it? You know, we're not going to see miracles in the first 2 years or 4 years. You know, I think sensibly they've looked at a 15-year plan, and it does take time to drive to drive that change through. And I hope that we can continue moving forward in that direction, even as governments change and as people in charge change. You know, the plan needs to evolve but continue to go in the right direction, for us to see that take effect. And you know, Billy, that I'm a big believer in that. All of us who sit in the supply chain, you know, we act as an agency for the NHS, but I believe that we all have an ethical duty to work in partnership with the NHS, and by that I mean helping them to achieve their plan and this goal. We all have a shared mission now of finding an NHS that's fit for generations to come. I have children, and that's made me even more passionate about it, because I want them to be able to access the NHS in their lifetimes and in their children's lifetimes. And I think we've all realised that the NHS can't continue. It was getting to a point where it wasn't sustainable, and we want to now create this sustainable model. How can recruiters, temporary staffing agencies work ethically alongside this plan and alongside the people that are at the heart of moving this forward? How can we help, do you think?
Yeah, I think. Well, I think in terms of, let's answer, can they help? Well, I mean, there's clearly a need for this, and there will always continue to be a need, for some of these temporary staffing solutions. And I'm minded, even today they published the pay review body report, and in that they've said, well, we've looked at the evidence around essentially London waiting, so the high cost area supplement, and there's no real evidence, so we're going to kind of leave it as it is. We recognise there's problems around it. Well, this just highlights the issue that the NHS has, where it's got, these often nationally set rigid frameworks, which define how staff are, are remunerated, and there are other terms and conditions. Even when you look at sort of international work, that's often how they characterise the NHS, as having slightly rigid employment frameworks, and that means you'll end up with, to a degree, a maldistribution of staff. We've seen it. There's well over 50,000 more nurses added over the last parliament. Many services and many specialties do not feel that. Learning disability being one obvious example. So you'll always have this, this uneven distribution. And we also know that the NHS has pretty poor experience in trying to bring in, recruitment and retention premium to try to make some adjustments around the edge. They tend to have unintended consequences, and they don't really evaluate them properly, if indeed they have any effect at all. So there will always be that need to have, those solutions to try to, to fill gaps when they occur, because they will occur for certain expertise, specialties, and location. So that's, the need. And then, well, how do you create a, a good market around that? Well, first of all, you need to be honest about this, and sometimes there's, from sort of national sort of commentary, there's occasionally sort of a dishonesty and attempts to sort of demonize some of the sort of temporary working solutions. And as you say, it's sort of really good that in the NHS workforce plan there was an acceptance of what does it look like in terms of permanent versus temporary, and the fact that that is that will always be part of the workforce. And then I guess it's something around ensuring then that there's a transparent and fair market to fill those gaps, and that's in part around national bodies have to sort of set the terms and parameters of that market, and then it's just about fair ethical behaviour of those within the market to do it. But I'll very much defer your judgment of, of how you feel about how best to get to that position.
Yeah, it's tough, isn't it? I think we just try to have as much conversation as we can around how we can align ourselves, but it's a tough question to answer, isn't it? And just to finish on, Billy, one big last question: if you were Prime Minister for the day, with regards to the NHS, because I'm sure there's lots of other things you'd like to do and change, but with regards to the NHS, what would you do? What would you change?
Yeah, I mean, maybe I'll be greedy here and try to steal a few. I mean, it'd be a busy day, this one. So I
A busy
think,
long day. Let's go.
yeah, yeah, let's go a long day. Um, the clocks go back, so you get an extra hour in it. So uh, I think we mentioned there about the scale of the workforce plan and the fact that it looks like can we even meet sort of patient need in a viable, affordable way, and even have enough people in the workforce to meet that, that the overall workforce, let alone the health one, to actually sort of to meet that. And I think there is something there about, and then we've talked about staff and their sort of relationship with the NHS, and I think I'd spend the first few hours trying to publicly redefine what that compact is between staff and the NHS, making sure there's an understanding on both sides in terms of who's investing what in it, whether it's the investment made by taxpayers in training, but also the assurances that in return for that, what would you expect to get, and how can you, allay some of the fears around will I get employed, and will I be treated fairly and paid fairly as a result. So there's something there about addressing the compact with staff, and I think there's something there about addressing the compact with the public as well, about what to expect to make sure you have a sustainable. So that's the first few. That's your morning gone, and uh, I think maybe I'll spend the afternoon pushing about in terms of a sustainable solution for the future. As I mentioned, there's a long history in terms of what works and what doesn't work. And there's an equally long history of the NHS forgetting those things. And it's been quite noticeable in the last, maybe even the last decade or so. There's been a really dropping off in the availability at all, and if they are published, the quality of impact assessments around some of these policies. And I think I would like to see a real return for the government when these policies are being created to have high quality impact assessment with an explicit and potentially independently checked analysis of what are the lessons from history, because we can't afford to keep on making them, particularly given the current challenge of the NHS, the current industrial relations with staff from the NHS. We can't make those mistakes. So yeah, I'd like to see those be improved. So I think those would be probably my 2 areas of focus.
That's a busy day, but I'll vote you in, Billy. When the time comes, I will vote
That's
you in
very
for
unwise to
that.
vote me in, but there we are.
You get my vote. Well, thank you very much. We've come to the end of our time. I could talk to you all day, Billy, but I appreciate that. You are a busy man. Thank you very much for
No,
joining
thank you.
us.
It's been a joy. Thank you.
And I hope you've enjoyed it too. I will.
Thank you.
I will be speaking to you again soon, I'm sure.
Yeah, thank you very much.